All right, we're going to go live on Facebook. Hang on a second, everybody. Airway Circle. We are live. Welcome, everybody. It is Thursday night, and we are here with wonderful Dr. Piya Gandhi. Welcome.
Thank you. Thanks for having me.
We are so excited for tonight's topic. I will let Angela do the honors and introduce our speaker.
Wonderful. Thank you, Renata. Tonight's topic is the journey to a functional pediatric dental practice, how you can transform your practice too. And introducing our speaker, Dr. Piya Gandhi has been practicing dentistry since 2009. She completed her pediatric specialty training at the University of Texas in Houston. Dr. Gandhi specializes in treating infants and children with airway disorders, including the diagnosis and treatment of tongue and lip tie. Her passion for tethered oral tissues was born from her personal experience and struggles with her older daughter. Dr. Gandhi has done extensive training beyond her residency in airway development and the diagnosis and treatment of tethered oral tissues. She screens all of her patients for airway disorders and oral restrictions, which could impact growth, development, and healthy sleep. She believes in the comprehensive team approach by using the function first model. She has worked to develop a network of practitioners in the greater Houston area, as well as in her practices. She is the founder of West U Pediatric Dentistry and Tanglewood Pediatric Dentistry in Houston, Texas. Her in-house team currently consists of a speech and language pathologist, myofunctional therapist, pediatric chiropractor, and international board certified lactation consultant. This allows the office to provide both convenient and comprehensive care. Dr. Gandhi is passionate about sharing her knowledge with other practitioners. When she is not seeing patients clinically, she can be found meeting with local practitioners for future collaborations or lecturing nationally to increase training and awareness of airway disorders and tongue ties. She has performed over 1,000 CO2 laser tongue tie release procedures, is an ambassador of the Breathe Institute and partner of the International Association of Tongue Tie Professionals. Welcome, Dr. Piya Gandhi. We're so happy to have you here with Airway Circle.
Thank you so much. I am honored to be here tonight and hopefully can share my journey and my experiences, and I am hopeful that it will bring other practitioners some knowledge and maybe some tips and tricks. And so I have a short presentation, and then we can open it up to questions.
Perfect.
Okay.
Let me know if you have the screen.
I'm going to go ahead and share my screen,
Okay.
and we can go from there.
Perfect. We can see it.
You can see it? Okay. Awesome. Well, let me get started here. Okay, so as was mentioned in the intro, we are going to be talking about functional pediatric dentistry this evening. And it doesn't even have to be pediatric dentistry. We can just even substitute dentistry into this, and the importance of looking beyond just teeth as dental practitioners. So I'm going to go ahead and start with as Angela mentioned, my journey, which started with my older daughter, Cyrah, who is now 9 years old. But my journey started with her when she was born. I was a first-time mother and didn't really know anything about tongue ties, even though at the time I was a general dentist. But, 4 years later, we figured out why we had all of our breastfeeding issues, why she ended up with sleep apnea at the age of 3. And I just got lucky in that I was in the field of dentistry and interested in tongue ties and was specializing in pediatrics. And everything sort of came together for me. But, for the majority of our parents, they don't have the opportunity to be in a place that I was, being a dentist and somewhat plugged into this world. So it has really made it my passion to educate not only other providers, but the community as to what to look for in their own children, because I struggled through breastfeeding and with Cyrah and sleep, and really hit a lot of dead ends as to what was going on. And it really put a lot of stress on our family and on her as a child growing and developing. So she has taken me through this journey several times, because the first time I released her, I didn't understand the importance of the functional providers that I now work with. So she went through a second release once we understood all of that. And then she's also the one that brought me into the orthodontic world and the importance of expansion and how it impacts sleep. And so I've really learned a lot through my children, and I'm grateful that I had the opportunity, even though it was very difficult, and hope to share that experience and knowledge with families in my community and really, all over the world. So as mentioned, I do have 2 practices here in Houston. They are set up very similarly, small boutique style practices. And honestly, when I opened them, I had no idea what kind of journey I was going to go on. I opened them as boutique dental practices where I knew I wanted to focus on knowing my patients more than just their need for dentistry, becoming an integral part in the community. And I had an interest in tongue ties because of Cyrah, but I didn't realize how deep I would get into this world. So I entered the world of airway through tongue ties. And when I started, it was just myself and my laser, which actually I started with a biolaser and then quickly transitioned to a light scalpel. But I started as just me and this idea of a boutique practice, started learning about tongue ties and really got into the tongue tie world. And then it kind of exploded from there. Currently, we have built our team quite extensively since I started. We not only have myself as a pediatric dental provider, but I do have 3 other providers in our office. And, none of them really specialize in this area of our practice. None of them do early or airway orthodontics or tongue tie releases. But what we've developed is a program of training our associates on how they can screen for you and how they can be an asset to their patients as well, because I don't get to see every patient in our practice. But what we've done is trained them to know how to screen and at least recognize the red flags so that they can internally refer to me. So we have the opportunity to screen all of our patients, not just the ones that are coming in seeking specific care because they know there's an airway issue with their child. In addition to having other dental providers, we also have incorporated a few functional providers in our practice as well. And this was really born out of natural collaboration that was happening with people in our community already. Also, the more we understood about the importance of these collaborations before and after and during ortho treatment, the more it made sense to just bring everyone in-house. Now, it's still really important that I collaborate with other people in the greater Houston and Texas community, because it's not always feasible for everyone to see our practitioners. And there are a lot of other great practitioners that we collaborate with. But I will say having these practitioners in-house has made care really convenient for a lot of our families. And it has really made our outcomes so much more predictable, because we are knowing that we have good follow-up. We know we're prepping these patients well. So I have been very lucky to find an IBCLC and an SLP and a dental hygienist, both of which are oral myologists, and a wonderful pediatric chiropractor as well. So we collaborate as a team, and it has really served our patients well. I would love to add to this. I would love to add a nutritionist and a PT, but all in good time. So far, I'm very grateful to have the team that I have today. As I mentioned, my journey in airway really started in the tongue tie world. So I have done a lot of tongue tie releases. Currently, I do treat birth through adults for tongue ties. And when I started, again, as I mentioned, I didn't really understand the importance of collaborating with our functional providers and linking in our primary care pediatricians or functional medicine providers. And as I went along my journey and learned and saw the results that my patients were getting, I really started creating what I thought was the best approach to treatment, which is where the function first model came from. The function first model essentially puts function at the forefront of our treatment, our goals for treatment, our decision making in terms of doing a release or not doing a release, because simply looking at anatomy does not, determine whether a release is needed, and more importantly, doesn't determine the timing of the release. And we all know that the timing of the release is really key in terms of the outcome of the release. Also, incorporating our pediatricians or our primary care providers, because if they're not looped in, then, as we know, this affects the patient's entire health. So we need them to be on board, or at least trying to understand what we're doing. So I have a whole lecture series on the function first model. It's actually a whole 2-day course that I teach. But just to let you know, this is our approach to treatment. It really lends to very predictable outcomes for all ages. And so if you're interested in knowing more, we have a blog post about it on my website, and I'd be happy to answer more questions about it. But that is just kind of one piece of what we do in our practice. So once I started learning more about tongue ties, I realized, wow, I'm missing like this whole other piece of the puzzle, which is growth and development, oral myofunctional disorders, airway obstruction. And now we know how closely linked all of these things are. So my journey into airway kind of came in from tongue ties, but now has exploded into so much more. So what is functional pediatric dentistry? When I started the practice, we certainly weren't branding ourselves or talking about functional pediatric dentistry. We were just a pediatric dental office doing tongue tie releases. I would say our transition really came during COVID as I educated myself more and started looking at structures. And now we have totally changed our practice style. So now we do call ourselves a functional pediatric dentistry office. And what that really means is that we are really understanding the connection between teeth, jaw development, oral musculature, and their impact on overall health. And the fact that the development of these structures can give us clues to growth and development patterns. It also gives us the opportunity, especially in a pediatric setting, for early intervention to either shift growth or, at least not make the situation worse. And all of us, most of us that are listening know the links between airway health and good sleep and cardiovascular health, and the downward cascade that this can have in both children and adults. So our goal is to really create healthy pediatric airways to give our children the best chance to thrive and also create healthy adults. So how do we do that in a pediatric dental office? I know we have heard of a lot of practitioners that decide to sort of leave traditional dentistry altogether and open up just an airway practice or just a tongue tie practice. But I know myself as a practitioner, I do love doing pediatric dentistry, and I don't want to stop doing pediatric dentistry to only do this. I love the fact that we can tie these two things together and do it all under one roof. It also gives our patients the opportunity to be screened for these things when maybe it's not even on their radar yet. So what do early visits look like in our practice? Early visits, and we're talking, under 1 to 3 years old. We are still talking about the normal pediatric dental things. We're still checking for cavities. We're still checking for proper tooth development. We're still talking about healthy diets, but we're going way beyond that. We're going beyond brushing technique and the use of fluoride or not using fluoride or flossing. We're really talking about the things that we can do at this very young age to impact proper growth and development. So we talk about things like breastfeeding and how we know that breastfeeding versus bottle feeding changes development, and how can we help support a family to do as much breastfeeding as possible. Maybe it's not 100% breastfeeding, but even some is better than none. And so that has to include knowing about tethered oral tissues and barriers to breastfeeding. So that has to involve screening and knowing what a posterior tongue tie is and how you can properly diagnose one, not just by looking at anatomy, but knowing what the functionality and how you can screen for functionality. Talking about transition to solid foods and talking about techniques like baby-led weaning versus the purees, because we know that baby-led weaning technique is much more beneficial for the growth and development of the oral musculature, including the tongue and maxilla and mandibular development. And then guiding parents on things like pacifier use. So in our practice, we really discourage pacifier use altogether. And, we really believe that if the oral musculature is working correctly, we probably don't need to be using that pacifier. So really educating parents early and planting seeds early. And again, looking way beyond teeth and coaching for, anti-cavity techniques. So just to talk a little bit about what that tongue movement looks like, and I'm sure a lot of you have seen this picture before, but when we're breastfeeding, our tongue is doing very different movements, really just lateral movement, and that really helps with that upper jaw development, versus when we're sucking on something like a pacifier or a bottle nipple or a thumb, we have a lot more cheek engagement, and that fights against our tongue really spreading things out. And so already we're having this tendency to have the narrow maxilla versus a wide developed arch, which we all know is beneficial for airway development. Similarly, this image as well is pretty popular, but what are we looking at in terms of growth and development now through 17 years old? A lot of this growth of our cranium and our maxilla and mandible is dictated by what these musculatures are doing. So if we see abnormal muscle movement, if we see prolonged pacifier use, we already know that we're going to have huge impacts on the growth trajectory. And early, you see under 4 years old is when we really need to catch things, even under 2, and change that trajectory early. So in our practice, when we start to see some things going awry, even early, the great thing is we have these awesome tools now, like the Munchie, which you can start at 6 months old, that can help already start building good oral musculature and changing the development of the upper and lower jaw and promoting healthy nasal breathing instead of mouth breathing tendencies. Then moving on to our childhood visits, similarly, like every other pediatric dental practice, we are looking at cavities. We're talking about parent involvement in brushing. We're talking about cavity treatment. And again, going beyond those things, we're looking at how things are developing. What does the upper and lower jaw look like? Educating parents on what they should be looking for. So all of our children get a pediatric sleep questionnaire to fill out. All of our children do get questions about their diet, not just diet in terms of are they eating food that causes cavities, but are they eating a wide variety of textures? Can they handle unprocessed foods? Do they gag on food? What does their sort of picky eating look like if there's picky eating? We're also talking about, do parents notice mouth breathing tendencies? We are screening for speech disorders, knowing the milestones of where kids should be at what ages. So when we're looking at smiles, what is the ideal smile? We're looking for spacing in primary teeth. We're looking for, not really deep bites where the upper teeth are fully covering the lower teeth. We're looking at anterior, posterior distances. What does chin development look like? What does cheek development look like? So a lot of people, will look at this and not think there's a problem, but a deep bite really means that our maxilla is not growing correctly. So you can catch these things really early and start to have the conversation with parents and do interventions at 2.5, 3, 4, 5 years old and change that trajectory. So even if you're not doing the treatment yourself, recognizing these red flags and knowing who to refer to. Similarly, a lot of parents think this is the perfect smile for their kid. Everything looks nicely aligned, looks like a beautiful smile, but really we know that this is crowding. Crowding is not just cross bites. I know in pediatric residency, I only learned that you put an expander in if you see a cross bite. Well, we know this kid right here needs an expander because there's no way that the permanent teeth can fit in and that airway is developing correctly. I encourage practitioners to know the ballpark of what intermolar distance should be at each age. And these are the minimum target intermolar distances. So we actually want to see way more than that. That doesn't mean that you have to take out a bullet gauge and stick it in every person's mouth. A really easy thing to do is get a cotton roll and see if it fits in the palate. And that's like a cheap way, an easy way to quickly see, are they on track with good transverse development or not? So these are just good little things to have in the back of your mind when you're doing your dental exam, and quickly taking into account, what does that palatal development look like? And do we need to have any intervention? Like I said, in our practice, everyone gets the pediatric sleep questionnaire. We are also asking questions about snoring, mouth breathing, bedwetting, things that we know that put kids at a higher risk for sleep disordered breathing. Now, none of these are diagnostic tools, but they do put kids in a category risk. And we know that these are signs that these kids are more likely to develop sleep apnea. In addition to the questionnaires, we also are using the Ferris 6 screening, which is fairly recent research that came out by Dr. Zaghi, but again, a very easy tool to implement. And when we talk about my associate partners, like I said, they don't do any of this treatment, but they know how to use the Ferris 6. They know about the pediatric sleep questionnaire. So they're at least screening and then putting kids in risk categories and seeing who's appropriate to refer for further sort of diagnostic records and things like that. This is a slide from my awesome myofunctional therapist in my office, Catherine Kangas. So of course, we know that oral myofunctional disorders play a big role in this. When our mouth musculature is not working well, we have disturbances in growth. We have impacts on feeding. We have impacts on speech. So knowing what an oral myofunctional disorder is, knowing red flags to look for, screening your patients for mouth breathing, tongue thrusting, looking at where their tongue is resting in their mouth. And it's not always about a tie. It can be hypotonia. It can be that we've used a pacifier for too long. It can be that we have large adenoids and we just can't breathe through our nose. But knowing what they are, partnering with a myofunctional therapist. If you're doing any orthodontic treatment, in my opinion, all orthodontic cases should have myofunctional therapy, because otherwise they're at some level going to relapse, because we have to think about why they got there in the first place. So knowing about oral myofunctional disorders and actively screening for them and then referring for treatment, and knowing how to look for tethered oral tissues. Tethered oral tissues come in all shapes and sizes. So it's not just about the anterior tie that's obvious to see or the very obvious lip tie. It's about the nuances of, knowing about posterior ties. Also knowing what their potential impacts are. So in some cases on toddlers, it's really hard to get a good look under their tongue. But what is easier is if you know that it's associated with picky eating and narrow maxillary arches, well, you can ask about those things and maybe more easily see that and suspect a tie, and then at least, start some therapy. So making this part of your screening process as well. Having some familiarity with speech mechanics. So I'm certainly not a speech language pathologist, but spending time with some speech language pathologists, even if they're not in your office, and understanding the technicalities of speech, because you talk to your patients all day long. Kids love to tell stories, and you can pick up on little nuances of their speech. A lot of parents, if you are a parent as well, you'll know that, your census is 1. So, or if you only have 1 child or 2. So a lot of parents think that what their child is doing is normal, when really they may be behind or their articulation may not be where it should be for their age. So knowing that, there are different sounds made in different parts of the tongue. And if you hear disturbances in those sounds, looking in the mouth and trying to correlate that to what you're seeing. Similarly, knowing speech milestones. on your 2, 3, 4, 5-year-old patients, what should they be able to say at their ages? Again, not stepping out of your realm or your space and trying to be a speech language pathologist, but just picking up on soft signs of disturbances so you can appropriately refer out. Also understanding solid food feeding mechanics. So I find a lot of people don't know that this is associated with lack of tongue movement, or can be tethered oral tissue or hypotonia. But for solid food chewing mechanics, you do need really good lateralization of your tongue. If you ever try to eat something without moving your tongue side to side, you literally cannot break it down. Similarly, if you can't elevate your tongue, you really can't move that food back down your throat to swallow it. So what I see a lot is kids with posterior ties will chew a meat and then they'll spit it out because they can't physically get it down their throat. So when you're asking questions about parents about their eating patterns, dig a little deeper. I always ask about meats if they're not vegetarian. And a lot of our parents will say, oh yeah, they eat meats. And then I have to ask them, well, what about meats that are not in a nugget, hot dog, shredded ground form? Because everything these days is sort of pre-chewed. And then we don't need our tongue to work very much. So a lot of times it's like taking the time to dig just a little bit deeper, especially if you're seeing something in the mouth that's giving you signs of dysfunction. So again, what is functional pediatric dentistry? It's tying all of these pieces together. It's looking at your patient beyond their teeth. It's asking the questions about sleep. It's asking the questions about feeding. I encourage everyone to have some sort of sleep screening in their office. And asking about feeding and having the conversations, not just because of their oral musculature and their oral function, but we all know food is medicine. So encouraging parents to really feed their kids more whole foods is going to be better for them overall. And again, not everyone is going to dive deep and want to treat these things, but I think it's our job. And in fact, the ADA and AAPD have said it's our job to make sure that we're screening for airway disturbances and sleep disturbances. So like I said, I think as pediatric dentists and dentists in general, it is our duty to look beyond keeping teeth cavity free. We have the privilege and the opportunity to develop our patients into optimally functioning humans. And I think as partners, pediatric partners, whether that be pediatricians or physical therapists or speech language pathologists, it is really our job to work together to really allow these children to thrive as early as possible. So I'm obviously really passionate about this stuff, but I'm also really passionate about giving practitioners the tools to actually implement these things, because a lot of us go to courses and we hear about these amazing procedures or whatever, and then we get back to our practice and have no idea how to implement it into our day-to-day lives. And so that's one area that I specialize in. I have a consulting company that does that. And so if you're interested in implementing, whether it be tongue ties or airways or the whole thing, other practitioners into your practice, please feel free to contact me. I'd be happy to start the process with you. Also along those lines, if you live in Houston or want to move to Houston, we are looking for another pediatric dental provider to join our team. And so if this, speaks to you, please feel free to contact me. And as I said, functional providers as well, looking for a good nutritionist. Anyone that wants to connect and collaborate, I would love to hear from you. So feel free to reach out. So that's all I have in terms of my little presentation here. I would love to open it up to questions if anyone has some. I know there are some in the chat.
Yes, girl, that was amazing.
Oh, thank you.
Fantastic presentation. We're having some people on, I keep looking over at my phone. I have some people on Facebook that are saying, Misty said, she's so excited to have that we have you over here to speak. But Dr. Hernandez has a question on our chat. She says, thank you so much for sharing your knowledge. When do you send patients for a sleep study? I'll start with that one.
Yeah, so that's a tough question. And actually, I just have started working pretty closely with a sleep physician here in Houston, a pediatric sleep medicine doctor. And I would say, when I look structurally at kids and we do CBCTs, and my first line is not always sending to a pediatric sleep medicine doctor. Usually what I will do is if we start early orthodontic or any orthodontic intervention, and we're finding that we're seeing some improvement, but there's still some significant disturbance happening and parents are still reporting symptoms, then I always refer at that point. But I don't do it sort of right off the bat. And I would say that's an area that I'm still learning about. And as we know, there are not great guidelines on to when we should be doing that. And sometimes, now that I have created a relationship with a sleep medicine doctor, which is a great thing to do, I would encourage everyone to do it. Sometimes I will email him and run the case by him and say, what do you think? Like, do you want to see this kid? Should we try this first? And it's really great once you start opening up the conversation. And I think initially I was really hesitant to do that because you never know what kind of response you're going to get. But I feel like you have to have these hard conversations to really open up some doors. And some doors will be slammed in your face, and that's okay. But when you find your people, they become, your allies, and then you get to collaborate and send a quick text or an email and make these decisions together so you're not on this island by yourself. So I don't really know if that really answered your question, but for me, I don't do it right away. We start some therapy, and if there's still some concerns and we're not seeing improvement, then we definitely refer.
Amazing. The second question was, at what age do you consider CBCT for treatment monitoring?
So I used to do it closer to 4 or 5 years old, but I recently took the advanced residency with Dr. Boyd, and he does it on everybody. And he does it on anyone that he's doing any sort of appliance therapy. And, honestly, there is a quick scan option on there. So, if I'm doing an expansion or anything on a 3-year-old, I'm doing a CBCT.
Okay, perfect. She said, much gratitude. And how old do you treat up until?
So currently I've really been treating up to 10, 11 years old. Once they're in full permanent dentition, I haven't jumped into that yet. Luckily, again, I have collaborated with a awesome airway focused orthodontist here in Houston. So he gets a lot of my patients. And similarly, if there's a case that I'm sort of on the fence about treating, I will collaborate with him, and he's very gracious to, give me his tips. But, at the end of the day, the question comes down to, do I feel like I can reach the goals of this family? And also, can I really help this patient function better? Currently in my practice, I'm not doing Invisalign or brackets and wires. So particularly if there's a family that wants perfectly straight teeth, that's not my jam. I'm not doing that. That's not what I'm currently doing. And so then I will send them when I know they need airway development and they want perfectly straight teeth at the end, then I will send them out to the orthodontist that I work with.
Perfect. I'm going to let Angela ask the next question.
Yeah,
but I just saw somebody over here on the chat. This Courtney said, so glad I was able to jump on. We are too. And for everybody that's watching live, if you guys are not an Airway Circle member yet, these are free live for everybody. But we have a bunch of a library, that's the word I was looking for, of other talks that we do every Thursday night. So for some reason, if you cannot jump on live, you're welcome to go back and listen to our library. If you're a member, it's only $25 a month. It's literally about $6 per each one of these Zooms. It's really a no-brainer. We do this to help bring awareness to the community and to other professionals. And we're connecting so many patients to professionals that it's insane with our directory. I was just talking to Dr. Gandhi about it today, but go ahead.
Okay. Joanna Wolska asked, and you did touch on this just a little bit, what are your preferred methods of palatal expansion?
Yeah, so it depends on the patient, but removable if possible, because then we can still work on our myofunctional therapy. I am trained to do ALF. I use the Schwartz appliance a lot. But I don't use the ALF very much because I find it relatively slow. And when we're talking about sleep and breathing, I want to get results a little faster than that. But I do have parents that come to my office wanting the ALF in particular, so we'll do it. But I would say the Schwartz is kind of my go-to appliance. I do use protraction face mask when we need to do things like that. Usually if we can catch them younger, then we do that. I also use the MyoBrace sometimes. I think it's a great tool to use to reinforce our myofunctional therapy. But there are very few cases that I will only use a MyoBrace in, because I find that we usually need a little more development, and sometimes we get some retraction of the incisors when we're using the MyoBrace. So I kind of use a combination of things, and the way I set up our ortho in our practice is it's a flat fee, and whatever appliances I need to use to get us where we need to be, that's what I use. Because sometimes we miss the mark. Sometimes we think a patient can handle a removable appliance and they can't. And the last thing I want to do is now go back to the parent and say, okay, well, now I'm going to charge you X amount more because now we need to switch the appliance. Instead, I'm just like, okay, this is not working. We need to pivot. And then we can very easily pivot. So that's the way we set it up in our office. It works great. But it's very dependent on the situation, and the buy-in from the parents. We need 100% commitment from the parents to get these things done. And in addition to that, all of these patients really need myofunctional therapy. So it has to be an appliance that can fit that in as well.
Amazing. Cherie saying you were an amazing speaker. Thank you for sharing. What signs do you look for that you would recommend a Munchie for a 6-month-old?
Sure. So it's not a lot of 6-month-olds that I give the Munchie to, but things that we're looking for are, one, I use it a lot if they're on a pacifier and we want to switch it so we can use it as a replacement appliance. Sometimes if we already see mouth breathing patterns, so you will see on a lot of babies, if you look at them, they're already hanging out with their mouth wide open. So using a Munchie can help with that. When we transition to solid foods, especially if we're doing things like baby-led weaning, if we're having trouble with our transition, or as we get to more textured food, we are having trouble, it's a great tool to use for tongue muscle development, because you have to think about a toddler's a pretty hard patient in terms of therapy. How much direction can they take? This is sort of a natural thing that we can use for therapy that plays on natural reflexes of toddlers putting stuff in their mouth and wanting to chew on them. Mm-hmm. It can also really help with teething.
Mm-hmm. That is so true. Actually, I have a little tip here. I used to put our Munchie in the freezer.
Yeah, that's a good one.
I would get it out for Benny to use, but my child is the opposite. He was never, no pacifier, and never wanted anything in his mouth. So I have a super hard time getting him to chew anything.
Yeah.
Which we all know he has all the issues. We have a question from Facebook. Fatina, she said, thank you so much. What do you do when there's a disconnect with the pediatricians? As the patient's parents ask for the feedback, how do you deal with that?
So as I had mentioned, I think in that function first model, you can use it for ortho or whatever modality you're doing. You're never going to have everyone on board. Okay, that's just the reality. I actually preface and try to prepare parents for that when we're having these conversations. I tell them, you may go to your pediatrician and talk about this, and they may totally contradict what I say. And it's not because one of us is a good practitioner and one of us is a bad practitioner. It's just because our training is different. And so I try to prepare them for that. And ultimately I tell them, you're going to have to do what you're comfortable with and what your gut tells you is right, is correct for your child. And I have a lot of education handouts. I have a lot of research papers. I also send pediatricians, if we have a kiddo come in that has signs of sleep disordered breathing, we're worried about airway development, we are recommending some intervention. I have an email that I send to pediatricians, and I have about 5 studies attached to it. Decent research studies that talk about how maxillary development improves airway, improves sleep, is a great addition to TNA surgery. So that's all you can do, is try to start the conversation. And, they may, still contradict you, but ultimately the only thing you can do is empower your parents to make the right decision. And that may not happen now. That may happen 2 years from when you started the conversation. But ultimately, you don't want a parent going into this type of treatment if they're not 100% a believer anyway, because there's so much commitment involved that it will fail if they're not 100% about it. So I wouldn't push anyone to do it. I would educate, plant the seed. I have plenty of parents that tell me, no, we just want to go the regular orthodontic route. Okay, that's fine. I'll refer you. It's fine. You have to partner with them. You can't work against them.
Oh, I love that.
I have a question for you. Do you ever use sutures after a tongue-tie release?
As much as I can. So the exception to that is babies. And I treat a lot of awake toddlers. So I treat toddlers awake till about 20 months or so, depending on how big they are. And we do that to really avoid a sedation. But those toddlers, those parents, I should say, have to be on board with post-exercising, okay? And we do a lot of pre-therapy and pre-training to make sure that they can do these exercises well. Everybody else, anyone sedated, anyone cooperative, always sutures.
Amazing.
Wonderful. Do you ever have to do, say a baby, do you ever have to do a 2-stage release?
So there are cases where I do. And the way I present it to the patients are, we may not have to, but it just depends on what your functionality and range of motion is after this first release. And really the thing that goes into that is they're so restricted that they can't do good pre-therapy, that we know that we're probably leaving something behind under there because we have, blood vessels in the way still and things like that are blocking our access. But so I try to make that up front during our initial consultation. We'll release as much as we can. We'll do therapy for 6 months or so afterwards, and then we'll see what you look like. We're not going in before then and redoing or touching anything up. But honestly, I haven't had to do many.
Amazing.
That's great.
Diane said, we are uniquely qualified to manage the growth and development of the craniofacial respiratory complex. Isn't that true? Amazing. Yes. Let's see. I have another question from Facebook. Veronica Cruz is asking, I know breastfeeding is ideal for those patients that are not able to do this for their baby. Is there a particular bottle you recommend to use for your office?
So, usually I would defer to lactation or SLP for this, but from just hanging around with my people and learning, I know that our IBCLC recommends the Lancino pigeon nipple.
Okay.
She, and her name's Leah Whitley, she's amazing. She says that mimics the breast pretty closely. Good. So that is what I recommend. And then I also tell them to ask lactation.
Awesome. Do we have any other more questions?
I have a personal question. Can you come over to Central Virginia and help me open a tongue tie center?
I would be happy to.
Yay! Thank you. Oh, yep. That was my one personal question. Great. I'm putting you on speed dial.
Anne is asking, would love to know the literary references. that you share with your pediatricians?
Yes, sure. So my email was on that last slide, and
I'll have
and I can put it in the chat too. If you want to shoot me a quick email, I'll be happy. Here, let me put it in the chat.
I'll email you. Anne is on Airway Circle.
Okay, then I would be happy to share it. Share those. Yeah, no problem.
Share with you, Anne. This is amazing. Does anybody have any more questions? Oh, Catherine said that Angela cannot have you.
She says, haha, you can't have her, sorry.
What does post-op care look like for peds and adult populations? Do you provide in-office demonstrations for the post-op protocol or educational videos?
Sure. So we have, I mean, it's different for every age group, and we have videos for every age group. For infants and toddlers in particular, we are really big on actually demonstrating hands-on and having parents do it in front of us. So what we usually do is we will do the procedure and then have parents feed if it's an infant, and then go over exercises. So I like to go over the post-care stretches, exercises, whatever you want to call it, once the procedure is done, because it feels totally different than demonstrating it before the release. And then we have parents do it in front of us, and we have videos of it that they go home with. All of my patients also have my cell phone number. And so if they're having issues, they usually call, but honestly, they really don't call very much. And then the good thing is once you have your network of providers, not just the ones in-house, but in your community, they all know what your exercises look like. They all know what your releases are supposed to look like. And post-care, they're all seeing, they're seeing lactation at 4 days. They're seeing body work at 2 days. They're seeing me at 5 days. And so then we get all of these touch points where people can see and adjust technique, or say they're really not doing this correctly. Sometimes they'll call me and say, can you have them come in earlier? So we definitely train a lot on that. For the older kids, I'm really, really big on telling parents, like, these are not stretches that they're doing themselves, because a lot of parents will say, oh, like my 8-year-old, they can just stretch their tongue themselves. And we know they're not going to be aggressive enough. So we have to show parents, and I show them after the procedure, like, this is how you get in there and do it. And you must be doing it for them. So yes, we are big believers on education in that. And sometimes for the toddler population and even older population, if they are not compliant with pre-therapy exercising, they're definitely not going to be compliant with post-therapy. So we won't do the procedure in those cases.
Oh my gosh. Did you guys write that down? How's it going? Now I have a personal question that I just thought about. Are you familiar with the herbs appliance?
I am somewhat familiar with it, but I have not used it.
Okay. I'm going to have to ask an orthodontist about that.
Yeah.
I just had a patient that got recommended the herbs appliance, but I don't know enough about it too.
Yeah, I don't know enough about it either to speak on it.
Perfect. Angela, you have one more?
I was on mute. Sorry. No, I was going to tell you today I had a new patient, and today was her first myofunctional therapy appointment, 6 years old. And she had a grade 4 tongue tie. She was tethered to the tip.
Yeah.
And her mom says that there's just so many problems, and everything that we know, the classic signs and symptoms she has. So now we're going to prepare her to have a second release. The providers in my area do not do sutures, and the majority of them use the diode laser, which is fine. And so it's just the whole preparation. What was that?
I said you have to work with what you have.
That's right. That's exactly right. And just prepping this sweet little girl who said that everything that I would suggest for her to do today, she said, no, I can't do that. I can't do that. I can't. And all I was asking is just open really big now just lift your tongue up, but don't close your mouth. We can't do that. And there was just so many cheers and praise and high fives today. Whatever it takes to get these kids into knowing that they can feel confident in doing this. But her tongue it will barely stick out of her mouth. And it's just, she's going to be so happy after we get her in there. And I think mom
have an adult like that now.
What's that?
Have an adult like that now.
Well, you're lucky that they found you. They are lucky that they found you.
Almost. They actually scheduled a frenectomy, and they asked the oral surgeon, I need a tongue tie release because I heard that it's going to help with my sleep. And the oral surgeon said, I don't think it's going to help, but I'll do it. She called me and I was like, why do you think you need a tongue tie release? Because I hadn't seen it. She says, well, I gasped for air at night. I'm like, don't get it done. Hold on. I need to see you first. Cancel the appointment. Let's talk. Let's see what we can do. But
anyway. I see that someone has a question in the chat, which I'm happy to answer.
Yes. About the billing.
Someone had a question about when expansion is considered very early, how is it retained over time? Do you combine it with myofunctional therapy appliances? So to answer that question, when we do it early, you do have to have some retention. I actually think using a myobrace as retention can work really well if you have the right patient and the right family, because it will continuously reinforce the nasal breathing and the right musculature. But sometimes we just can do, either leave that appliance in that we have used, or do like a regular retainer. So it just depends on the kids. But if we can use a myobrace, I like to use a myobrace.
Good to know. Awesome. There is a question about billing any of your services to medical.
Yeah, so we are currently working on that. We have gotten some of our CBCTs covered, and we are working, actually we just signed up today, to start getting, hopefully, some of the myofunctional SLP and lactation covered. In terms of actual releases getting covered, we currently just give all the paperwork to the parents filled out. They just literally need to put it in the mail. But I don't bill directly through medical for tongue tie releases, just through dental. But we are really trying to get the myofunctional piece, because especially when we're talking to parents about ortho treatment plan, tongue tie treatment plan, myofunctional therapy, I mean, these things just really start to add up. And so the more we can get them reimbursed, the more it makes things accessible to more of our population.
It's the truth. And hopefully all of you.
Sorry?
There's three of us. Sorry, we talk a lot, y'all. To continue Dr. Hernandez's question, we skipped because we thought that you had already answered it. We are using the myobrace, and are you using the myobrace and just adding myofunctional therapy?
If she's talking about during retention, we're not generally doing myofunctional therapy for the entire retention time. But if they still need therapy, then yes, we will continue therapy. But if they have sort of graduated from therapy, I think the myobrace is a great reminder of what we're supposed to be doing, because it's so easy to fall back into old ways. I mean, I see this with my girls. That's why I like using the myobrace as a retainer, because it also helps remind our patients of the myofunctional side of things, not just that we're keeping the teeth in the right place.
Yes.
And the jaw in the right place.
I have another question that I'm not sure if we can answer from Facebook. Nicole Pingert said, do you have any experience with the froggy mouth appliance? Indications for its use over the Munchie?
No, I don't.
Catherine, do you know anything about it? I know she's here. Does anybody in the call? You guys can unmute yourselves. We have about almost 60 people in the call.
Yeah, that's awesome.
Together with Facebook. That's amazing. And then if while somebody is thinking about how to unmute themselves, if you guys want to comment on the froggy mouth. Veronica said,
Catherine said, I've heard of it, but haven't used it.
I have heard some good feedback.
I have one. It's upstairs in my room. If you want me to go get it, and I'll show you how it's worn.
Sure.
Okay, y'all keep
I'll
talking.
ask Veronica's question. Okay. Veronica said, I know early intervention is key. From your experience to find that the patients that you do releases for infants or toddlers are less likely to see you again for ortho? Did I?
I think the question is, if we do an early release, will that, make them less likely to?
Okay, so if you
ortho?
release an infant or a toddler, have you been noticing that they don't need ortho in the future?
So infants, for sure, but that depends on what the parent has done between the release and when I see them.
So much.
If we have been sucking on a pacifier the entire time, well then they're in the ortho category. But if they truly, not that this is a good thing, but I have seen, because my practice is only 5 years old, I have seen some second and third children and not the first child as an infant. Sure. And so we kind of have some, little research experiments going on, but it's amazing to see how the second and third child that I released as infants, how their growth is totally different from that older child that I did not see as an infant. So I definitely think that there's early intervention is definitely the way to go. It gives the child the best chance of naturally developing rather than needing all of these other interventions.
Amazing. Well, Angela's going to demonstrate to all of you the froggy mouth.
I'll just show it. So this is, let's see if I can turn my light off there. So this is what it looks like. And your lips come over on top of this.
Oh, interesting.
And it's hard. It's like a hard plastic, but it doesn't come together.
I heard that it was good for tongue thrust.
Yes, and that's what it is supposed to be. And so you use it for tongue thrust. And I did try it on one of my clients once, and she was not a big fan of it because she tried it for 1 month and then kind of put it to the wayside because it didn't work for her. Now, I'm not saying it's not going to work for everyone. I don't think she was consistent with it on a daily basis. This has to be used for 15 minutes every day, and it activates I think it activates it's controlled by the trigeminal nerve, and it activates something about your neural sensories. And it kind of
forces you, if your lips are open, it's going to force you to swallow without using your lips. I think that's the whole point.
You got it. And then when you take it out, your lips should naturally just come together and you should swallow without, because you're so used to having it separated that you want to close, but this is forcing your lips to not close during that 15 minutes. So when you do take this out, your lips will naturally come together and you will continue to swallow.
There you go.
But you have to be consistent. Just like with anything else that's removable, you have to be consistent with it.
Well, guys, I have an invitation to all of you because it is 9 o'clock. This Tuesday, we have a special event coming up. We are super excited. We have all of the masterminds. Myo masterminds are coming to talk to Airway Circle on Tuesday at 8 p.m. Eastern Standard Time, or daylight savings time, I guess. But if you guys are available, it's going to be live at 8 p.m. or 5 p.m. for Pacific. We're going to have Laylee, Sarah Hornsby, Anna, Sanda. We're going to have everybody with us. It's going to be fantastic. Their new course is coming up. And Catherine did it, right? Catherine just graduated from them?
Yeah. Yes, she did.
Catherine, I don't know if you can, I know I already invited her. Maybe you're not ready to turn your camera on. There you go.
Hi.
How was my mastermind?
It was good. I'm hiding from my kids. Hold on.
Yeah.
It was amazing. It was such a great course. It was more than a course, I have to say, honestly. So many great different topics covered throughout the 9 months, from body work to fascia to ortho to surgery to post-op care. I mean, all of it. It was phenomenal. And I have to say, just the relationships that we built as a class is something that I was not expecting, because we weren't together. We were all virtual for 9 months. But when we all came together in March in LA. It was so much fun. It was just like, we have a bond now. So if anyone is, doing myofunctional therapy and kind of looking for another course, I promise this is not a paid plug. Sounds like it, but
okay, we just did the froggy mouth. We're talking about everything. Hi, Bray.
I highly recommend it. It was fantastic.
Awesome. Well, we hope to see everybody on Tuesday with us to hear from these amazing women that are going to be joining us. And then on Thursday, we have Nicole Archambault, my dear friend. Super, super excited. Thank you, Catherine. Thank you so much, Dr. Gandhi, for spending this hour with us.
Yeah, no, thanks for having me. It's fun.
Thanks, everybody. We'll see you next week. Angela, I want to say bye.
Oh, thank you so much for being here. From everybody here, we're so grateful that you are on this wonderful journey as one of our leaders in the field. So thank you for always offering your great support to all of us.
All right. Bye, everybody. Good night.
Good night.
See you all next Tuesday.